good evening, and good night, friends and colleagues from across the entire world. Thank you for joining us today. Today we bring you guys the ultimate show with the person that's known as the father of modern dentistry, Dr. Gordon Christensen, hosted by Dr. Arash Hakemian. Welcome, gentlemen, to our first webinar of the day.
Thank you. Thank you for having us.
Good to be here.
It is quite a miracle that on the same day that we have Dr. Christensen with us, we have also surpassed the 1 million mark of peers reached as we write history together. Over 150 doctors have participated in this peer-to-peer project selflessly to bring knowledge and education to our colleagues from across the world. We started this project with the top 100 doctors, which was essentially speakers and innovators and educators and so forth in the industry and the supply chain. And today it has turned into the top 1 million project. And I remember podcasting Dr. Gordon Christensen during those times a few months ago, and we had great laughs and we learned a lot from each other. He's all of you guys know him by his wonderful clinical courses and also his products report. And Dr. Hakemian will emphasize on that much more. Ladies and gentlemen, peer-to-peer works. We can solve any problem together in a lean, mean system. And I invite you guys to develop more and more peer-to-peer platforms in our industry. With that said, Dr. Hakemian, you have the floor.
Wonderful. Dr. Christensen, such a huge honor, pleasure to have you. Dr. Christensen is a living legend in the field of dentistry, needs no introduction. He's one of the most recognized dentists in the world, the founder and CEO of the Practical Clinical courses, one of the most comprehensive and well-respected training programs in dentistry. He's also the founder of the Clinicians Report Foundation and the Clinic Product Report, which all dentists look to for great recommendations and reviews. Dr. Christensen, you're actually part of my alma mater, USC graduate.
Yes.
That's where you see your dental degree, but you also attended the University of Washington, where you received your PhD, and also or was that in Denver? You received your
University of Denver.
You received your master's at Washington.
Yeah, Washington. I did a prosthodontic.
And yes. 2 honorary doctorates. You actually helped initiate the University of Kentucky, the dental division, and also the Colorado Dental School, and also taught at the University of Washington, I believe. Both sons are dentists. Family of dentists like mine. I think both of your sons are dentists. I think William is a prosthodontist and Michael is a GP.
Right.
And yeah, I can go on for days and days. Diplomat of the American Board of Prosthodontics, fellow in the ICOI, fellowship in Academy of Osseointegration. I think your resume, if I want to go through it, will be here for for the next 45 minutes. I think we're all so excited. We have a large audience watching from around the world. I've had the pleasure of meeting you several times, and we all look to you for credible and up-to-date information. And I'm excited to jump right into it, and we're all really happy to have you on. So with that, I'll let you go ahead and get started and take the floor.
Thank you. Do I just click the program? Put it into presenter mode. Yeah. Okay.
Yeah. Hang on 1 second, Doc. Let me go ahead and put it up.
Okay.
So it's gonna be up in about 1 second, and then we're gonna get you right there, and you can go to full screen mode now and begin.
Is it up now?
Yes, you got it. You're on.
Okay, is it full screen or partial screen?
No, you got to go into full screen mode.
It's in full screen. Okay, good.
No, it's impartial. You got to still go into.
Oh, you want me to put it in full screen?
Yeah.
Oh, okay, we'll do that. There we go. Wonderful. You know, I just got off a 600-mile motorcycle ride, so if I look a little sunburned today, I'm sorry. We do a lot of crazy stuff. In spite of my age, I have not slowed down at all. I'm approaching my 4,000th presentation right now. I elected today for this group, not knowing how many of you know implants or don't know implants. I've been doing implants 37 years now. to do a simple program, one that I think anybody can do unless you're afraid of blood. Inexpensive, predictable, easy treatment of the edentulous mandible. Is that not the most miserable thing you and I treat? Of all the things we do in dentistry, I'd have to say very few times has somebody said, wow, that's a great lower denture. I'm a prosthodontist. I doubt if I've had that more than 10 times in all the years I've been practicing. Bottom line is, I have a lot of people putting words in my mouth. That's the group we have at the CR Foundation and at Practical Courses in Utah. We invite you to come. This is going to roll pretty fast because I have about an hour to play with you. The white coats there are the in vitro group. If I have a question, and we get thousands of them a year, that's the group that does a simple study and figures it out. The green coats on the right are the in vivo group, and they spend years. As an example, we must have right now about 18 years on zirconia crowns in the mouth. What's the black group on the left? They're the group that puts the courses together. We exist not by government money, not by company money. We take nothing from each. We make educational products, and that's how we've survived 43 years at this point. I'm going to give you quite a few references to various educational things we have as we're going through this. Everything on this program, basically, has been through CR research, Clinicians Report Foundation. And if it's not faster, easier, better, and low cost, you don't want it. I guarantee you. There are a couple of websites. The bottom two, or the yellow ones there, cliniciansreport.org has about 10 years of research on it. If you subscribe to the report, you get that free of charge. If you don't, it's a minor charge. PCCdental.com, for those of you around the world, we have an international study club that I'll tell you a little bit about later. But that particular group is literally around the world. I'm on the internet 5 minutes per week on the question that's most asked that week. As an example, some time ago, well, for the last about 3 years, here's the most common question. Why are my zirconia crowns falling off? Unbelievable. And yes, that can be really easily. You don't have much retention on the prep. The internal of the crown needs to be roughened in the pre-centered stage. I just answered it in one long sentence. That took about 1 month and about $50,000 to figure that answer out. Zirconia crowns do fall off because you have a piece of putty underneath a brick. You got the analogy? What's the putty? Resin cement. It's resilient. What's the brick? Zirconia, which is like a rock. That's why they come off. You have to have retention, mechanical, not just some esoteric bonding agent. Well, a couple of things I'd love to have you do in this miserable COVID time. My wife's Dr. Vella Christensen, PhD, microbiologist, virologist, actually did a 3-hour program on real world infection control, not the junk you're getting on the internet right now from all these governmental organizations, a bunch of politicians trying to tell you, look at that video, you're going to get the real word. How to disinfect, what products are actually going to work. And then one other thing coming very shortly, this is June 20, I will be on with taking your practice back with all kinds of administrative things in 3 hours as to how to get back in this miserable time. I'm back, been back the last 2 weeks. On completion of this presentation, you should be able to. Can you read that? I won't read it. You can read. I want you to be able to do this simple stuff for edentulous mandibles. And I know you will like to do it because it does work. It works. My feelings about prioritization of dental implants is on the screen. Resorbed edentulous mandible is the singular most problematic thing we do on a routine basis in dentistry. You try to think of anything on a routine basis that is so disdained by dentists. They say, oh, here comes that old lady with that miserable lower denture. I hope she dies soon. You don't say that, but you really feel that way. The yellow ones there now are secondary uses of implants, and the white ones, you can do a lot of conventional stuff that's pretty well. If you don't know what all those classifications are and you can't remember them from dental prison, the Kennedy class 4 is what? No lower anterior teeth. Oh, the denture flips up in the back. The Kennedy class 1 is what? No teeth on either side in the back part of the mouth. What's the Kennedy class 2? No teeth in the posterior on one side of the mouth. And what's the Kennedy class 3? Just a missing tooth here or there or everywhere. So red means it's not a pleasant thing to do. Yellow means, yeah, you can do it there. And white means it's okay to do implants there, but often I'll elect conventional dentistry in a 3-unit bridge instead of a single implant if the contiguous teeth on either side are defective. You know, you look at those Edentulous mandible that are models, obviously, and there are about 40 million people just in the USA. Just in the USA, out of 320 million people, we got 40 million people in this so-called first world country that had their teeth ripped out. I would say many of them had them ripped out that didn't need to come out. My old dad, who's long dead, had that happen to him at about age 40, and he crippled down about like that mandible on the right when he got in his 60s, 70s, 80s, died in his 90s. But one slight punch in the face and it'd probably break that mandible. Absolutely ridiculous. Alternatives for conservative treatment of the edentulous mandible. You can read that. I'll say it simply. 2 implants. Number 1, conventional diameter, 3 millimeters and up. Or 2, 4 small diameter implants. What are they? 1.8 to 2.9 millimeters in diameter. You will see them. They've been condemned by some erroneously and wrongly so. We'll support them in a minute. Or how about 4 conventional or small diameter implants, 2 in the anterior region and 2 in the posterior region, followed by an overdenture? Well, there are 3 easy ways. If you're not afraid of blood, you're not half blind, your both hands work, you can do those 3. Okay? If you don't know this, you're under a rock somewhere. Carl, a very good personal friend of mine, now probably look down here wondering why he's had to go that early. Those are his 4 classifications, and we use them constantly. And we have 4 levels of implant courses in our group of 13 courses. We have 13 courses. They're 2 days each, and we're doing them all virtual right now. But just as soon as this miserable COVID-19 is over, we'll go back to face-to-face. I am a PhD psychologist as well. And although you get something from a program like this, you do not get the real meat, because I don't even know if you're there. I could be talking to the wall. I can't see your eyes. I can't see your smile or lack of it. I can't see you're playing with your trinket or drinking a cup of coffee. So virtual will stay, but to get the real stuff, come to a normal course where you actually can do it. I'm convinced, and all the says that the virtual is good, face-to-face is excelente. Radiographs for implants. What do you need? What do you need? This will upset some of you because it is not what is considered to be normal. Panoramic is your major educative tool, absolutely no question. Panoramic should be sitting right in front of the patient, about 16 inches out. And the patient sits down and they look at that. And I'll ask them straight up, what do you see? What do you see there? Well, what's that gray spot? Well, that's where there's a little bit of disease around the root of the tooth. What's the white couple of spots? That's fillings. They block the radiation. The panoramic is an unbelievable educative tool. Now, what's that extraoral bite wing? The second bullet down versus the next to the last bullet down, intraoral bite wing. You're all probably doing extraoral bite wings or intraoral bite wings? I think you are. We've just about eliminated intraoral bite wings 20 years ago. That's when I got on cone beam. I was one of the first ones in the world to get on cone beam. We now have 3 in our clinic. And I wonder how I got along before, because I've been doing implants 37 years, and I've had cone beam only 20 years. I could have killed several people in that first number of years. Now that I look back and think, wow, how did I get along without cone beam? Well, I'm going to show you examples of all these. Do we do periapicals routinely? Let's stay with implants for a minute. Yes, even though I might use a guide from time to time. And let's say I have 6 millimeters between 2 teeth and I'm trying to put a 4 millimeter implant in there. I don't trust all of the guides. I said that slowly. There's several good guides: my 2 fingers, my eyeballs, my knowledge of anatomy. And occasionally the guide is as good, but not always. So don't worship guides. That comes in a second level of implant course that we provide. The first level is freehand. That's where you learn to feel the bone. That's where you have to know the anatomy. That's where you do take a couple of periapicals to see right and left. If I'm too close to a tooth and I nick it, guess what? The tooth wants to die. And there's gradually a disaster for you. Well, what about cone beam? I've got 3 things there that are going to force you to do in developed countries legally: implants, impactions, and some endo. The intraoral bite wing, as I said, I haven't done it for a long time. And the full mouth series, what's that? None. Some of you are from Great Britain, and I'm not trying to impress you, but I am a fellow of the Royal College of Surgeons of England. One of my primary methods for identifying caries. None
Ladies and gentlemen, I'm going to get Dr. Hakamian back in while we are waiting for Dr. Gordon to log back in. So while we are waiting for the technical issue to be resolved, Dr. Hakamian, please tell us a little bit about your experience of participating with this peer-to-peer project and the ideas and the foundation behind it, and what we have achieved thus far.
I think it's unprecedented. Bringing some of the best speakers from around the world. You guys have now reached over 1 million different views around the world, which is unbelievable. I'm almost as shocked as Dr. Christensen saying we don't have to take bite wings anymore, which is great news. Great news.
Yeah.
No, but in all seriousness, I think this has been a tremendous movement. We've had participants from just about every single corner of the world, every single country, and your team has done an excellent job in really sharing this information. And now more than ever, in these unprecedented times, we have to share good information and bring this information free of charge to dentists who are looking for good advice and recommendations on how to start back their engines and how to really thrive on their way back into opening up their offices. So we thank you and your entire team. You guys have done an excellent job, and it's such a unique pleasure to be a part of this.
So what do you think the ramifications are for our peers, 1 million peers that have seen the videos or have participated in some capacity, and how many millions and millions of patients they can help? COVID wasn't bad to us. We had the opportunity to get to make a lot of friends, and also to make a lot of friends, and also discuss and absorb this information and knowledge and apply it. So you wouldn't have otherwise been. You're a lot more prepared, don't you think, for post-COVID now?
Oh, I think at the beginning, I think we were all just scrambling, not knowing what to do. But this is, again, a sign of how we unite as dentists and come together and really now using technology to share information quickly, efficiently, and allow people to comment and respond and ask their questions. So I think this is going to be a new wave into using technology to be able to now do remote mentoring and monitoring and disseminating good information. So yeah, I think it's wonderful, and really happy to be a part of it.
All right, so I see Dr. Gordon is back. Give me 1 second.
Yeah, I want to hear about how we don't have to take PAs in Bitewings anymore. This is this is the highlight.
Funny, right? He's funny indeed. Let me see if they're probably getting their camera setting going.
Oh, wonderful.
So give it a setting. Give it a second. Yeah, the first time I podcasted Gordon a few months ago, he's very frank about his position on a lot of things, be it mini implants, be it a lot of controversial issues. So it's fun to listen to Gordon for sure.
Actually, I think we were having dinner we were both being inducted into the International Academy of Facial Aesthetics. And Dr. Christensen was actually the one who inducted us. So I remember meeting him and having dinner and some drinks with him. And he's as fun in real person as he is on webinars.
Sure. He is quite a person. Just imagine dedicating your life and career on a particular topic and excelling at it. So, but again, technology has sometimes it has its deficiencies. That what it has enabled us to do with leveraging technology and social media and the goodwill of our colleagues. I mean, you're talking 150 people that 150 plus that have not only dedicated their time and lectures and their social time, but this is something you would see at a major conference, these presentations, and we can now do it from the convenience of our homes, and bring this knowledge to our, you probably traveled for what, 10, 15 years taking CE all over the place, correct?
That's right. Yeah, I've traveled from LA to Vietnam to South Korea to Brazil, Mexico, all over the world. Now we just do it virtually, quickly and efficiently.
Right. Technology has certainly changed our world, but that also creates places of opportunity for our colleagues to do more and more of these type of scenarios.
We're trying to be in, and it says waiting to go live on our screen.
Let me see, show and stream. I have, you don't,
Stream.
yes, you need to go ahead.
There we go.
But we can't see you yet.
We're almost there.
You're almost there, guys.
Right, it's on the phone. We'll get it taken care of.
Okay, I'm gonna go ahead and get off, Dr. Hakamian. If you want to go ahead and talk about anything you want, dentistry, cats, I don't know. Just I'll be right. I'll be right back.
Well, for those of us who are joining today. I invite you to go back and actually look at some of the previous webinars. They are posted on the Global Summit, and we have amazing lecturers coming on talking about a variety of subjects. I know right now we're all looking for answers and recommendations on how to get back. But in every situation, there's always a silver lining, and this is an opportunity where we can really catch up on our CEs, catch up on a lot of these courses that we haven't had, unfortunately, the time to do while we're practicing, and we can come back together really strong. I think with this new information, learning how to incorporate these new technologies, different modalities, whether it's surgery or cosmetics or teledentistry, I think all these things are going to play a crucial role. And when we get back, try new things, try some new procedures, try some of the things that you guys have learned, and really try to push your practice to bring in new procedures and new services that you previously weren't offering in order to try to relieve some of the pressure that we have. I know that there are a variety of different courses. Unfortunately, we can't maybe visit them in person, but when I started my career, I would often refer to, I would sometimes go on YouTube and watch 20 or 30 or 40 different videos on a particular procedure and really reinforce it. And this is kind of the same thing, except it's coming from amazing, credible resources like Professor Christensen and others who've been on this platform. In the very near future, we will expect to have a lot more of these, and in fact, we'll have some remote monitoring where you can actually have your mentors be able to supervise and oversee procedures as you're doing them in real time. And so the use of technology is really helping shape this new post-COVID world. For those who do not know, I participate in teledentistry and telemedicine, and really excited to see that expand around the world. And it's just one example of how we're using technology. I was listening to Dr. Christensen, and I really agree with him regarding the point that he made as far as the implementation of implants. I think, I've been placing implants for over a decade now, and I think for those dentists who haven't previously ventured into the implant world, I mimic his recommendations in recommending that you guys start. Implants are a really quick and easy way to expand your services. And when you learn how to place implants, you're not only learning how to put a screw inside of the jaw, you're learning how to cut flaps, how to suture, how to do GBR, bone grafting, after extractions, and also really helps with the treatment planning. When I realized that my ability to properly treatment plan required a really in-depth knowledge of how implants work, and they're such an integral part of our practices now. I also agree that I think mini implants, as he was mentioning, are a really helpful tool in practices. I started off placing mini implants actually, and really the amount of bone that you can save, the amount of circulation that you can maintain, and the avoiding of big ridge augmentation and other types of bone grafting required for wider implants can be avoided with mini implants. And so I invite people to really look at enrolling in some courses. And honestly, with mini implants, oftentimes if you have an issue, you back it out and the bone fills in, and life goes on and you can continue. And I really invite people to try mini implants, get involved in the process, and then work your way up to higher diameter implants. Whether you're using it for dentures, denture retention, and many people have started using mini implants to actually restore single teeth. So I think that is a viable option. I'm interested to hear more about Dr. Christensen's view about Bitewings and PAs. And in my offices, we're still actively taking a lot of intraoral x-rays, but with the advent of these new technologies, we might be able to avoid having to do these. So We will wait for a couple more minutes, and hopefully we'll have Dr. Christensen back on. Apparently, he just came back from, I think he's at a 100-mile motorcycle run. So he's an amazing man. His family is filled with dentists, and we look to Dr. Christensen's reports, all the new products and services that come out. The first go-to place. Oh, there, we got him back. Dr. Christensen. I was just saying, I was talking about your product report, and I was saying every single thing, new technology that comes out, we look to your products report to see how they're doing. So I'm glad you're back. I was reinforcing your recommendations for mini implants and telling dentists that they have to get involved and really start learning about implantology. And most important, I think this is the most exciting part. We still take a lot of Bitewings and PAs. And you were just at the point where you were saying you may not need these anymore. So I'm really excited to finish up where you left off. So welcome back.
I'll go back to that. So I share screen now, right?
Yes.
And there it is right there. And we will make full screen. And let's go where we were. Okay. Oh,
yeah, just got it, guys. Just got it. Hang on. Let's pull it in.
Hey, now that one, go back to the first though. Should I go to part screen and go where we were?
Yeah, go back.
Yeah. Okay, let's do that. And we were right about where I was saying periapical, I think. Yeah, okay. Hey, I think we're in business.
You're in business. You can go full screen mode, and peer-to-peer fixes everything, even technology.
Okay, sorry, you guys. I hope you had a good coffee break. And we hope this thing's running. We've got good bandwidth. I don't know what happened. Here we go. We did a study not very long ago on handheld periapical devices. When you see a CR choice on any one of our reports, that means of these that we tested, that was the best. And here you go. As I said, we take no money from companies, we take no money from the government, and so what you see is what you get. This girl in the, I can't say girl anymore, the feminazis get mad at me. This woman is shooting this dude, and that little thing keeps any radiation from getting back to her. And if I were standing right over on the left side of this person, I would get nothing. Get one of these and get rid of the miserable wall-hung mounts. I'm frustrated every time I try to use a wall mount because you're banging that the holder for it, and get yourself a handheld, and that one is by far the best one. Intraoral Bitewing. I want to share something with you. Here's an intraoral Bitewing of a given person, and they're looking at it, and they don't know what they're looking at all. How come you have two of those? Well, one goes back a little farther than the other. But I don't see any bone up there. Now let's just go forward to extraoral Bitewing of the same patient. What am I seeing? Well, I'm going to go back now. You're seeing just the crowns of the teeth. You're not seeing any bone. What am I seeing on this extraoral Bitewing? Highly educational for the patient. We're going through outer space to get this image to you, so that the image is not as good as it really actually is. You're seeing basically when the image is adequate, you're seeing infraalveolar canal, you're seeing sinus. If the sinus is there, you're seeing from third molar, which is not there on this mouth, clear on into the lateral incisor. And we're using that now for caries identification. It's not that accurate. None of the radiographs are, as I said. But cone beam, oh boy. This is the grandfather of cone beam, Plan Mecca. That's the first one I had, and that's 20 years ago. Here are the current versions on the left, and I'm going to put a rectangle around the one that satisfies most general dentists. That particular one will do everything but sleep medicine. Look down here on the lower right-hand side of the screen, and you will see the various sizes, the volumes that you can get. And a typical general dentist doesn't need the head. Prosthodontist does. Oral surgeon does. A periodontist often does. Several groups need the full image, but most of us don't. And the radiation is so low on these, it's fantastic. As I said before, those 3 yellow ones are what are going to drive you to CBCT whether you want to or not. They'll drive you illegally. I already have been involved with several lawsuits helping dentists to bail out when they did not have CBCT. I'm going to play this little video for a second. This is an oral and maxillofacial radiologist and me, a prosthodontist. And this is video 1174, which just gives you some kind of an idea where we are right now. Sorry, hit the wrong button. There we go. I'll bet that almost everyone watching this video is doing endo almost every day of their clinical life. You know that endo treatment comprises a major part of the GP's gross income. And to satisfy patients, it must be fast, easy, predictable, and at a moderate cost. However, research reports show that up to 20% of American endodontic treatment is still somewhat problematic for the patient. And you and I can't figure out what it is unless we can flip those images and look at them in a little bit different orientation. Cone beam significantly helps to determine why a tooth is still symptomatic. Dale is now going to show us some examples of just what I've talked about.
Well, Gordon, in this example, what we have is an axial plane of section thin slice through the maxilla, about the mid-root region of the molars. And if you look at the arrow on the right of the screen, you can see that endodontic treatment has been performed, and there is an MB2, in that particular tooth, mesiobuccal canal 2. With the tooth on the left side with the arrow, you can see that one hasn't had endodontic treatment, and you can actually see the canal. You would never see that with conventional, periapical imaging. Interestingly, if you look up on the left side of the screen as well, you'll see a first bicuspid, which actually has 3 canals in it, which is quite unusual. So, if you had to do endodontics on that tooth, you would do the endodontics, but on the other hand, the patient would be back whining within a couple of weeks saying, I thought this was supposed to calm down. It didn't calm down. There you go. And you wouldn't know what was going on without an image such as that. Okay. By the way, anything we have, because of COVID and because of my desire to help the rest of you who might want any information we have, if you use this discount code MAY20, and you put in either one of those, pccdental.com or the 800 number 223-6569, yeah, just tell them you were on this program and it's 20% off. Anything. But that's the video, a little segment of it. They're all an hour long. You get 2 hours of CE credit for them, 1174. Now this, Dale gave me this one, Dale Miles. He's the oral and maxillofacial radiologist that I happen to use. The patient was having pain in the second molar. I have no idea who did this. I don't want to know. It's not bad. It's been done by a general dentist. It's a little short, but short's better than long. And they got down the street to an endodontist, and 70% of endodontists now have a cone beam. And what did they find? Do I even have to say another rut and a lot of resorption? It's time to get a cone beam. Here's an example relative to our presentation of today. Here's an osteoporotic woman. You can see all of the voids in the upper right-hand image, all of the voids of osteoporosis. That would be a score over a 2.5, a T-score. As you look down here to the middle image, that represents the red lines. And you'll see we have 4.46 millimeters facial to lingual. The bone looks pretty dense, but 4.46, I can't get a standard diameter implant in there. I need 6. So we sit in front of the screen. The patient and I are looking. You have no bone in the back, as you see from the lower right image. We can either trim this down to that blue line, and I never say cut because they get excited, they have a stroke, but we can either trim this down and put a wider one in, which I do not like to do and usually will not do, or we can put a small diameter implant in there, which we successfully did, and they've now been serving about 7 or 8 years. They happen to be 2 millimeters in diameter. There are lots of these cone beams out there, folks. It's extremely confusing. You need to go to a large meeting eventually when you can go anywhere. And you look at those, what have we got on there? 6 examples that represent different characteristics. Some sit down, some stand up, some have icons you can read, some have icons you can't even understand. Some are low cost. The lowest cost on here would be Carestream, Prexion, and Vatek. Some will make an unbelievable panoramic. Vatek will do that. I've not seen better panoramics, and also external Bitewings. Get yourself adequate cone beam. Here's an example of what the lowest cost Vatek provides for you. You can read that on the right. Unbelievable. That runs in US dollars around 65K, give or take. That's the lowest level. Most general dentists are more than happy there unless they're doing sleep medicine. There's my summary for radiology. Read it. I would have to say the most important sentence on there is the bottom one. Get access to cone beam as soon as possible. As soon as you can rob a bank or do something, sell your kid and get a cone beam. If you're really down and out, well, financially, and you may be going back, get at least a ridge caliper. This is a blunt end from Salvin. As you can see, it goes facial and lingual on the ridge. You read it over here. Let's say I read 10. I have to take a millimeter off the facial, millimeter off the lingual for the soft tissue. That means I have 8 millimeters of bone, facial lingual. Not bad, not bad. You don't know really the density of the bone, but you know there's bone there. So that's the least you can do. What about size categories of root form implants? Small, intermediate, conventional, wide body. Read that while I'm talking. And interestingly enough, the small diameter implants, which came out and were cleared by the American FDA in 1997, were condemned by oral surgeons, periodontists, miscellaneous folks. The only people they were not condemned by were real world general dentists who said, I don't want to go through the ordeal of a standard diameter implant. And the patients can't go through it sometimes. These are 1.8 to 2.9, jump up. These are around 3, jump up. They're 3 to 6. And then they got these big wide body ones, 6 by 6, fat and short, fat and short. These were condemned by particularly oral surgeons when they first came out. These were, and these were. They're eating their words. This became legitimate subsequently. And lo and behold, in the last several months, the small diameter implant in many mouths where there are small and also conventional in the same mouth. You want to hear this? These are looking better with less peri-implantitis than the conventional diameter. Now eat those words. I'm pretty interested to tell you that because I've known that now after thousands of these have been placed in the mouth. I mean, okay, they are very different. They're a screw. So what? These widen the bone. These are like making a, I've done thousands of these too. These are like making a grave and putting a casket in the grave. These spread the bone. If I have 4 millimeters of bone, and this is 2 millimeters, let's say, it'll spread the bone to 6 millimeters. Well, you look at the screw thread. Obviously, that's not the size of the implant. That's this exacerbated here. And you can see these are blunt end. These are pointed. I wish more standard diameter implants were screws. They're not. By the way, if you want more information, you probably got your phone. You're probably watching this on your standard computer. Go to pccdental.com and you will see. In fact, I'm going to click it and you'll see what comes up. pccdental.com will come up with all kinds of information on it. So if you want that, just go to it, and that is live at the moment. That's our catalog. Okay, and there we go. Technique 1. Let's go through these techniques. It looks like since we had a 10-minute stall there, unless you guys tell me otherwise, I'll try to go to about 15 after the hour. 2 conventional diameter implants and an overdenture. Now, how much bone do I need? Conventional diameter implants are 4.5 in diameter. They're usually about 12 long. I need 6 millimeters of bone in the facial lingual dimension. I need 10 in the crestal apical. 10 is 10, 10 and a half, 11, 11 and a half, 12. That's the most standard length. I need 1 or 2 millimeters or more from the vital structures, and I need preferably 5 millimeters from the metal framing to put a standard diameter implant in. Let's take that case. These are preliminary casts made by a dental assistant from an alginate impression. And here's a neat product for you, Snapstone. It sets in 5 minutes, and you can trim it in 10 minutes. That can be done right while I'm doing a diagnostic appointment. I can look at the patient, show it to them, and what an educational thing. These are custom trays made in Dentsply Triad by a lab or a dental assistant. You don't have to do that. 80% of dentists don't do a custom tray. I prefer a custom tray by far. Can you see the 2 wells down in here in the tray on the lower right image? Now, this one is going to be spheres. Spheres. We're going to do something else in a minute. This is one of the techniques. These are available from Stern Gold. You tell them what length of collar you need, put a periodontal probe in, find the implant, which would start right at the bottom of that gold-colored material. And let's say that's a 2 millimeter collar. I want it to stick out about 1 millimeter. I'll tell Stern Gold I need a 3 millimeter collar for a whatever, for any brand name of implant that's major that you know. There are now 500 brands of implants. Then over the top of that in the denture is processed a ring with a little rubber tire in it. The rubber tires go about 6 months to, I've had them go 18 months, and they cost an enormous amount, $1 US. This is real world dentistry. Okay, it's going to be screwed in. There's your transfer coping, and there they are in the mouth. Now let's follow this patient. There's the impression of the upper done in 3M Permadyne, which is a polyether. It could be also Aquasil. They're my 2 favorite ones. And you can see the border molding has been done in heavy, heavy, heavy. I've perforated through a couple of places, so let's trim that. Here's the lower. And now there I perforated through, and there are the 2 implants. We have perforated through the tray. So now there will be a layer over the upper, a layer over the lower. I can assure you, done properly, I wish I had you in a couple of day course. Sometimes I can't even pull the lower one out. I never could pull the upper one. I have to have blow on it to get it out. There's the previous dentist on the right, and there's me on the left. What a difference. Most general dentists don't seem to get it in dental school, how to make an impression for a denture. Hey, I'm going to leave it on that slide for a minute. This is a custom fitted so-called bite block. It's being a prosthodontic, I should say, occlusion rim. Make a final cast, make a thin layer of triad over it, trim the oxygen inhibited layer off, place adhesive in the tray, and the lab tech makes a VPS, vinyl polysiloxane impression, inside the tray. You will not be able to pull those out of the mouth if you've done your impression correctly. I see dentists using wax. I see them using all kinds of suck downs. Get a good interocclusal record there's an interocclusal record now made on a custom bite block, which you can see go back and look. This is blue, so that's underneath that. And there are the dentures. And now we'll try them in and do the adjustments. After the processing, there are no rubber tires in there yet, no rubber rings. And then what? I'll go inside of that with about a number 2 to 4 burr and make a 1 millimeter relief. So when the patient bites on that, it has a shock absorber in it. It goes up and down about 1 millimeter. I'm going to probably jinx myself, but I've never really had a failure of an implant doing this technique with a resilient situation. There goes the rubber washer in after I've adjusted the denture, and away you go. And there she was on the left, before, and there she is on the right. I adjusted that denture, and I'm not trying to brag. It's the impression that makes it go this way. I had one adjustment. Okay, here's technique 2. 4 small diameter implants and an overdenture. Or they could be large diameter implants, either one. I'm going to take it as small right now. That's 1.8 to 2.9. The only thing that's different from the slide I showed you before, you see, is that first one, 3 to 4 millimeters of bone in the facial lingual dimension. 10, 1 to 2, 5, they're the same numbers you saw before. So really the only difference is the facial lingual amount of bone. And as I said before, you either cut that bone off and make it wider as the bone widens as you go apical, or you put a small diameter in. Main reasons, I'll paraphrase that. Inadequate bone quantity. The second one, inadequate bone and no money. The third one, inadequate bone and sick. Number 4, adequate bone, but sick again. And number 5, most people, when you even intimate, I need to take 4 millimeters of bone off there, they'll say, huh? Do it on yourself. I don't want it on me. That's the all on 4 concept. I won't even do all on 4. I've done many all on 6s. I've done many all on 5s. That goes clear back to the Brandemark time. If you have one fail, big whoopee. So what? I've got a spare tire. If I do 6, I've got 2 spare tires. Well, anyway, we're not in that ballpark today. We're in simple, simple, simple. These are 9 commandments. Can you read fast? Read these as I click down this line. If you do all of these things, small diameter implants will work. I will guarantee you they will work. If you do not do all of those, even 1 or 2 will kill a small diameter implant. Gotta have good quality quantity. You've got to have 30 centimeters to screw it in. Now we're going to lengthen out to 13 millimeters, not 10, 11, 12. And they got to be pretty parallel because the bone's usually thin if you've elected to use these. There's only one on there that is a real problem, number 5. And bruxers or clenchers will screw up anything you do. I don't have to tell you that. We're teaching 3 of these. All of those work. We're teaching 3 of them in our level 1 course. The level 1 course we have in implants is basically small diameter implants and conventional diameter implants in healthy people with good bone, singles. Anybody ought to be able to do that. Level 2 goes into sinus lift. It goes into multiples. It goes into guide. Level 3 goes into how to restore them. And level 4 goes into how to resurrect, if you will, the 45% that, according to Gothenburg, Sweden, the heart of implants, according to the major studies done there, 45% have got peri-implantitis of standard diameter implants by 9 years. I'll pause and let you think that over. We thought implants were going to be God's gift to dentistry. They are not. They're the last resort. The last resort. Right now I'm seeing many good teeth ripped out just to put an all-on 4 in. Don't do that unless you absolutely have to. There is nothing like a tooth. Did you hear that? There is nothing like a human tooth. Glidewell Laboratories, what about them? They have 3 sizes. They're all straight. Those 3 sizes are excellent. You can pretty well see how they are. They have a very good little holder. You get a hold of that, you put it in one end and then take it out and pinch that bottom end on that gold thing you're looking at, and the thing comes out. There are the 3 sizes, 2.2, 2.5, and 3. 3 is right on the borderline of a small diameter and a large or conventional diameter. They're straight. That's the least expensive brand. Intralock now has been around for a good long time, and they have the LPRF centrifuge concept too, and BioHorizons sells these at the moment. The threads are excellent. The top ball is 1.8. They have an angle if you want an angle, and they're about about a fourth of the ones that we place, you need an angle. That angle is 15 degrees, as you can see on that slide. 15 degrees is enough to satisfy the 15-degree lack of parallelism of the mandibular posterior area, or about the premolar area of the upper arch, or that's pretty obvious. Look at that slide. You can see that 15 degrees will bring that ball right back into the center of the ridge, rather than sticking out like a coat hanger in the front. And yes, you can do maxillary. We've done many maxillaries. If the bone is dense, fine, you can use 4. If the bone is not dense, borderline, don't load it immediately. We are loading most of these immediately. That slide, I'm just thinking now, how long is that? We're still seeing this patient. That is about 16 years on a small one, and the only thing I see is a little bit of loss there. I'm not saying anything else. You try that on standard diameters, you'll see 45%. You'll see there are 4 stages of implant degeneration, and you would that one would be classified as a level 2. Okay. Zest is an unbelievable company. Now you're jumping up to locators. And this particular system has been excellent. This is small diameter now at the 2.5. And now here's a company that put a point on a 4 millimeter collar there. And this one is a 2.4. And that one is a 2.9. They're both small diameter implants. 4 millimeter collar, 2.5 millimeter collar, the same kinds of retentive features as you're well familiar with Zest. But you've got a more rigid attachment. It's got a metal cap on it, as you can see there. Okay, why can't I change the slide now? Sorry, I've got a block on this for some reason. No, there we go, there we go. How do you like that? That's the first implant company in the small diameter where they got a 10-year guarantee. I've given you 3 choices there. Now think about this. All 4 of those cases have been in the mouth at least 18 years. Look at the bone on this lower right one. Every time he comes in, I think, you must have some relationship with the good Lord, because that shouldn't even be in there. That was 4 millimeters of bones I screwed in at 1.8 millimeter diameter implants, those 2. I put standard diameter in his upper arch, and you're not looking at his upper arch there. And the small ones look better than the big ones at this time. Let's hit technique 3. 4 small or conventional diameter implants and an overdenture. Watch this dude. As I told you, I have a doctorate in psychology as well. And this is an unbelievable physiologic and psychologic orientation on this boy. Look at those eyes. Look at those eyes. He has a master's degree. He's an educated person. He had money at one time. When I treated him, he was a street person. Why do you think he's growing that beard? Because he doesn't want people to see his teeth. He didn't tell me that, but I certainly could surmise that. Well, sometime in his life, he had money. Sometime he had a divorce. He went through a job problem. Life is bad. There's so many suicides, so many people like this now. Those of you who are in the state of California, you know the problem you're having with street people. My goodness, I used to live there in California. I lived a 10th of my life there, and I'm just sorry to see that happen. Well, there they are. What are you going to do with them? What are you going to do with them? Whatever caused all that disease is not going to go away psychologically unless we really buoy him up. He'll stay just like he is. We took him out. Okay, the lower was out already. You can see that. So we took the uppers out. And I'll let you scan that while I'm talking. A patient like this, you're involved with their entire life. This is not just a minimal amount of dentistry. And you're looking up and down the line. We did him in a fairly normal kind of a sequence, and I'm not taking the time to go through that. Custom trays, and I strongly like the custom trays. And there you're looking at 4. These are stern gold implants and ERA attachments over the top. ERA is much like Locator. ERA was the grandfather of Locator. You may not know that. And there are the dentures. And now this is the actual laboratory orientation. And look, I've cut a little hole in the back of the denture on the lower right image to let the material ooze out as we're picking those up. And now here's the lowest level of retention. I want you to just gaze at that for a minute. Is that a different person or not? What do you think? What do you think? He went back to work. He got remarried. You don't just fix teeth. You fix people. You see the face of that individual is not the same. Well, he got fat too, but in the meantime, that's my fault. He got teeth. We're changing lives. You and plastic surgeons are the only people who can do that. You realize that. You cut out a gallbladder, 6 weeks later, you don't even know you had it done. You fix somebody like that, that changes a life. Well-placed small diameter implants are successful. Who's saying that? Just Christensen? I don't think so. 2 slides here. Expected success of small diameter implants. I suggest to you that you go on the site PubMed, P-U-B-M-E-D, PubMed, and you start looking for the success. There's the second slide of small diameter implants. These are various times, and they're not the kind of thing that will fit into a meta-analysis. They're individual studies, but they're pretty darned impressive. I'm going back. Do you see anything under 90% there? No, you don't. I'm frustrated as to why these things had a bad reputation right at first. I never had a bad reputation with them. For me, they were easier, faster, better, less expensive. Well, I've been around 45 minutes or so with you. Did we do these following things? Differentiate, discuss, and compare 4 different size categories. Well, what did we show you? We showed you small, we showed you large. And we showed you the super large, and we showed you the ones that were kind of intermediate. 3 techniques. You saw 3 very conservative treatments. Let's use US dollars for just a minute. The first treatment I showed you, which was 2 large diameter implants, it runs around $5,000 or $6,000 US dollars. Now, some of the countries listening where you live, that would still be expensive. If you add 2 more implants, you know the cost of the implants. In the US, they're around $2,000 to place the standard diameter, around $1,000 to place a small diameter. And I've hit a few techniques for materials and devices. Let me just tell you some of the things we have. Coming up June 5 and 6, I have a virtual 2-day course on implant surgery 2. If you know a little bit about implants, that's the second level up. That would be a good course for you. There's how you get into it. And I've got an all-access pass. If you go to our internet, tccdental.com, turn to page 3, you'll see what that is. That's all of our educational materials. Here are the top 10 videos. Look at those top 2. If you go to, I'm going to spell this out very, very slowly, cliniciansreport.org, CLINICIANS, clinicians, no space, report, R-E-P-O-R-T, cliniciansreport.org. Pull up the homepage, scroll down to the bottom. There's all kinds of free stuff there for you that will get you infection control. Not these videos, it'll get you information that we've written on it. There are top 10 at the moment. And those of you who are somewhere in lower Slobovia or somewhere, our International Study Club goes all over the world once a week. I'm on the internet, 5 minutes per week on the question of the week. And if you want to come to Utah, if you can't find something to do on there, it's hopeless. That's why I live here. Look at all those things I can do. Thank you for the opportunity to be with you for a few minutes. Now, what do I do? Just punch stop sharing, you guys? I think so.
We'll take care of that. We're going to bring back your host.
You're going to do that. Okay, good.
Hang on 1 second. We're going to bring back our wonderful host here. I'm going to hide your presentation. Hang on, doctor. Let me switch you guys up. And there you go. Let's discuss questions.
Do I stop sharing now?
Yes, you can stop sharing.
Hey, there we are. Look at that.
Dr. Christensen, amazing presentation. I have so many questions, and I'm going to also ask some questions from our viewers who are sharing their questions on our as we go live. First and foremost, I'm so happy that you're discussing this. I personally found this to be true in my clinical practice. I was placing a lot of the mini implants as was recommended by, or the smaller diameter implants as was recommended by a lot of our peers, more for temporary reasons, right? Maybe holding up the denture while we're waiting for the ridge augmentation or for the traditional, but I would come back at the end when I was ready to restore my regular implants, and all of my mini implants were perfectly integrated, and I felt so bad, wanting to take them out, and actually I ended up leaving a lot of those in there. And I completely agree that 2, 3, 4, 5 years down the road, some of the smaller diameter implants are doing better than my traditional implants.
That's a national statement now. We're seeing that.
Right. So I mean, but let's discuss why. Do you think it's attributed to better blood circulation since we're not disseminating, really taking away so much bone and circulation? Do you think it has to do with other reasons? What is the reason behind this? Do you believe?
That is an absolutely super question. One of our courses that John Suzuki and Kevin Suzuki and they're both great on provide. We just finished it virtually this recently. We'll do it again. I went through 20 different reasons why implants are failing, and among them is the juncture between the abutment and the implant, which oozes bug manure, if you will, all around the edges of that interface. As I look at situations on patients where I place conventional diameter and small diameter, and the small diameter look better in most of the cases, I'll see the bone diving down on the conventional diameter, right where that juncture is. You know it just as well as I. I think that's one of the major reasons. Then also it's a less traumatic technique to put a small diameter implant in. And another reason is you're spreading the bone. You're condensing the bone as you screw it in. It's not just a casket with a grave, putting that casket down in the grave like a center diameter. I think there's several reasons. As I said, I wish more of the conventional diameter implants would have points on them. Not quite as aggressive as the small diameter, but we need to be condensing that bone.
Yeah, and so on the procedures where you're placing these, are you opening up flaps? Are you actually opening a flap for all these? Or are you doing some of these flapless?
Thanks for that question. That's a good question. We polled the profession to see what they were doing, and we found that 80% are not making a flap, and 20% are making a flap. And when would you make a flap? Well, if the bone is irregular, or you have a sort of a Mae West situation where it's big on the top, and then there's an indentation, big on the bottom, you need a flap. If you've got exostoses, if you've got situations where they've been in an accident, one side of the bone is higher than the other side of the bone, then a flap is necessary. If I feel questionable at all, regardless of the size of the implant, I'll make a flap. I'm more of a flapper than the normal average that I just gave you.
And with that said, some of the issues we get with the bone loss are actually caused by creating the flap in the first place.
Yeah, and at least a millimeter goes anytime you make a flap.
Right. Opening back up for a second stage, putting a healing cap, all these are actually contributing to some of the bone loss.
Right.
Yeah, and another point, which no procedure is perfect, and sometimes we can do everything perfectly, standard protocol, and sometimes things fail. And what I found is taking out traditional diameter implants sometimes decimates the bone. We have to correct. And so the removal. Yeah, I'd like to discuss that for us a little bit.
The removal of an implant, which is obviously stage 4 of implant failure, that's the last resort where you have maybe a fourth of the implant still remaining in osseointegrated, and using a trepide burr and taking that out, as you just said, destroys that bone. You've already probably used the widest diameter that seemed appropriate for the amount of bone that was there. So to take out more bone, that's pretty threatening. And frankly, I've only had to do that a few times in my career. Usually, if they fail, they're loose, and you can take them right out.
Exactly.
Basically, there's just a small amount, and that would be stage 1, 2, and 3 of implant salvage, where you then can go in, either lay a flap or not lay a flap. I usually lay a flap there, go in with little titanium rotary brushes, clean out the debris out of the threads, and then blast it with a glycine. It's not a hard technique, and graft it, suture it back up. And I'm going to say I'm not optimistic on the third stage, but the first and second stage, very high success. The third stage, 50% success. The fourth stage, you're taking it out.
Right. Yeah, I think when I first started, one of the things I did as a huge differentiating factor for my practice was I would have patients show up, and unlike some of our other dentists in the area, I would place their implants same day. Immediately, they would leave out with some type of a restoration. I would actually load these immediately, same day, and I wouldn't, as you mentioned, I wouldn't remove any bone. I actually would go in with my high speed and do my initial osteotomy with a high speed and just hand torque it. Amazing initial stability, and they would walk in happy, unbelievable. No ridge augmentation, no nerve lateralization, no massive GBR, and at a fraction of the price. And I would collect my entire payment up front, and they would leave happy, and they would refer tons more patients. I think this is going to be critical now that we're getting back into performing, opening up our offices and trying to get back into the groove of things. I think that all clinicians, all dentists should have some level of experience with implants. And not only does it help with restoration of teeth, but it helped me with so many other procedures, with my extraction, with my treatment planning. And I really, really mimic your recommendations on how important implantology is. Now, have you had a lot of implant fractures? I think that's a concern some people have, that these implants are, not as strong and they're fracturing. What's your experience been with fracture rates?
Now, I'm not normal. Now, I know that because I've taught occlusion for well over 40 years. One of the major reasons for implant breakage is fracturing because of occlusal stresses. I've seen dentists take removal or fixed prosthesis right off an articulator and put it in the mouth and send the patient home, not touch the occlusion. I've seen the very experienced dentists do that. There's only one articulator, it's right there. And that articulator forces me to adjust. I don't care what kind of an articulator I've used. That I have let's just take something severe, like an all-on 5 or 6. As I said, I don't like all-on 4 for various reasons that I'm not going to here. We'll put it in, and let's go back to the screw form. We're not using the screw form now. We're using the FTX from this. But let's go back to the screws for a minute. We would screw it on, leave the holes open, and adjust the occlusion at the seating, and there would always be some adjustment. 24 hours later, I've got them in again. we will look for food debris. They've eaten 2 or 3 meals during that time. We would clean the underside, which I'm not seeing with all on fours now. They can stack their lunch in there and have a snack every 15 minutes, suck it out from under that miserable non-contoured apical. So that's 24 hours later. Then I'll do it again in a week. And then I'll do it in 6 weeks. Only then will I feel comfortable with the occlusion, because everything changes. The muscles change, the implants, some will have more stress than the other, and there's movement there. So I think one of the major challenges that we're looking at is lack of occlusal knowledge. They're not getting into dental school. I can guarantee you that. That's all they get on occlusion is how to spell it. When they get out, there has to be some occlusal orientation to make those things work. If I think back, this sounds really egotistical. As I said, I'm very occlusal oriented. I can only count, I'll bet I could count it on both hands over 37 years that I've had fractures. Not very often.
All right. Yeah, and one of the things that it kind of reminded me of when I was starting to get into the smaller diameter. Do you remember the old endodontic implants that would go
down through teeth? Yeah.
Yeah. Whatever happened to those? I there were so many people that spoke against it, and I had a bunch of my colleagues who placed it, no issues. I have actually done about 10 of those, and I've never had any issues. They kind of remind me of one another, no?
Yeah, well, let me use some kind of an analogy. One of my first encounters out of military and a couple of graduate programs was being chairman of operative dentistry at the University of Kentucky as we started that school. And so I got into a lot of research on pins and posts and all kinds of things. And we found that only one type of post or pin was very biologically acceptable. Now, with a post, it wasn't strong enough. With a pin, as you know, when you screw down a pretend a pin into a tooth and go 2 millimeters in, you occasionally miss. You're down in the meat. Well, interestingly enough, with the pure titanium pins, and that the name of that for you listening is Phil Pin. The company is Phil Hall, Filpin and Filhol, and you get it from any one of your local dealers. But there's not a problem. I'm not encouraging it, but I'm just saying if you do happen to make a pin go in there, it's the same thing with the endodontic situation.
So I wanted to know, what are your protocols? In my office, we start patients on Paradex about 2 days prior to the surgery, and I also start them up on antibiotics. And not only have I seen this help with patients actually showing up, it's kind of like starting the procedure 2 days before it occurs. Less cancellations, they're already on their antibiotics. We really control the environment. I also start them on some supplements, make sure they address their diet. What are your protocols pre and post implant placement?
Pre and post, basically we're using antibiotics. However, my microbiologist wife is frustrated with that. But then I ask her straight out, if you're having an implant, would you prefer antibiotics or not? And then she weaseled around and finally said yes, she would. But don't just use a slight dose. Use the whole dose. We have determined that. And probiotics. The probiotics are very adequate as well when giving a female antibiotics. The probiotics, there's a little company that we prefer, and it's Claire, starting with a K, Claire Probiotic Company. So prebiotics and antibiotics together, the women don't have the same mucous membrane problems that they have otherwise. So that would be the only deviation I see from what you're doing.
And then do you advocate chlorhexidine and Paradex use after surgery? Because I know there's divergent theories on these. Some people actually think that it's affecting the healing process and that it may be overkill. What are your thoughts on
There is some literature on that. It's one of those meta-analysis where you get the same old tried statement that really frustrates me. We need more research on that. Well, yeah, obviously we need more research on that. You see that every meta-analysis is supposed to be the highest level of research. I never get an answer. The only answer I get is on smoking and implants, and then everything's negative. But almost every other thing, I had to give a paper for the American Academy of Implant Dentistry a while ago. I had 1,300 in the audience, and I got more out of their hand raisings than I got out of the stupid meta-analysis. And I'm sorry to be critical of that. That's supposed to be the highest level. But it always says, there's research on this side, research on that. You got to make your own decision. Well, I knew that, idiot. So I'm ready to say on any one of those questions that is debatable, it's got to be a personal judgment related to the individual patient and their apparent challenges and the personal history. There are other real negatives, such as severe periodontal disease before the teeth are extracted. And if you get any knowledge about that, those who are listening, before putting an implant in, that's probably one of the most, next to smoking, it's probably one of the most severe problems relative to implant failure and peri-implantitis, previous problems with periodontal disease.
So I have a couple other quick questions for you. If you have the time. And these are things that I always really struggle about getting good answers. And I trust your judgment. I trust your experience. So I want to ask you some of these things that I've been thinking about.
Go ahead.
What are your thoughts about the use of PRP, PRF, CGF in implantology and how it's developing and really affecting the surgery world?
We did a significant study on it about 5 years ago, and without trying to bring up any more slides, I'll just tell you the story. LPRF has had unbelievable success among those who have used it. And Intralock, as I said, now sold through BioHorizons, is one of the major devices. There are 4 centrifuges out there. The one from BioHorizons is cleared through FDA. I fully think the others would be cleared too if they went through all the Mickey Mouse, I'll say it, paperwork to get FDA clearance. So what's happening? The bone within weeks has turned relatively dense. The healing is faster. The people who use this concept are very positive about it. But let's go to the meta-analysis, both sides again. So we've got to be careful that we're yielding our judgment not based just on 1 or 2 studies. I'm positive about it. That's the bottom line.
Yeah, I actually started a couple of years back. I started doing some of my sinus lifts with no bone.
Yeah.
CGF in there, the tenting technique worked perfectly, and lo and behold, I've come back and there's tons of bone. I didn't have to introduce any type of foreign sources or products, and it's been really instrumental for me. And the patients love it. They're not used to getting their blood pulled at a dental office, and watching the centrifuge and watching the process has been amazing. One last question before we go, because I know you touched on the radiology aspect of things. For 2-part question. So do you believe that CT scans are the standard of care for implants, and can we continue to do implantology without the utilization of CT scans? And then tell me where you think the next couple of years are headed as far as artificial intelligence in not only implantology but in dentistry as a whole, in diagnosis and in other aspects.
I have some mixed views on that whole concept. The artificial intelligence is definitely here. There is absolutely no question there. Of course, we test devices and concepts and drugs and materials and procedures. And in looking at several of them at the present time, they're here, much like an automobile in 1903. And I'm saying that pretty candidly. I asked the last one, and I'll leave names out, I asked the last group that we tested, how much variation can I expect in it? Say I've got 2 teeth that are 6 millimeters apart, and I'm putting a 4 millimeter diameter implant in. How much deviation might I expect? And I got as high as 1 millimeter. And I thought, are you kidding? So right now, much of it is still in the developmental stages. We're looking right now at recruiting a man who is heavily involved with artificial intelligence. That's gradually going to be very useful in cutting crown preps, in doing miscellaneous things that are the simpler ones. I think the human brain hasn't quite been approached yet, not even replaced. It's still got a ways to go, but gradually it's going to come. I forgot your first part of your question.
I want you to leave us with this. As everyone now, our brothers and sisters around the world, our colleagues and peers are looking for guidance and advice and some kind of a reinforcement of how do we get back to the norm. If you were to leave us with one piece of advice on dentists who are thinking about getting back to practice, some of our older dentists are scared, the hygienists are up in arms and worried about the aerosol formation. Give us some words of wisdom and some encouragement on how to get back to some type of normalcy.
I'll make one statement that will upset some of you. I've been back 2 weeks now. The most dangerous thing I do during those 2 weeks is going to the grocery store. I'm very serious. You use all the precautions. You've got to use the right face mask. I hope you'll go to that video I showed right at the first that I said Dr. Rella, my wife, did. That is 3 full hours on how to get yourself ready to go back. The right face mask, the right disinfectant. CDC is saying Clorox. I don't want my whole dang office to smell like cat urine. And that's what it does with Clorox on there. High ethyl alcohol is about the only thing that really kills fast enough to use it. I could give you a day on infection control, but we don't have a day. So the bottom line is use the precautions we know. Make sure, now I'll tell you my protocol right now. Patient can't enter the building. They call from the car. I'm here. Okay, walk up to that door you see. Okay, out comes the front desk person. They shoot them in the head with the thermometer. If they're under 100.4, I still get nervous at even 99. I'm going to be a little nervous. You've been sweaty running over here. Okay, so we'll shoot them. They'll put a face mask on. They will put gloves on. They will walk back into an operatory that has been prepared for whatever we're doing. It will have a barrier over it. They've got gloves on, so if you're touching the chair handles or anything else, I'm not getting the office contaminated. When they're done, on goes the face mask again, on goes the gloves again. They walk out. They will not talk to the front desk. The front desk goes outside to talk to them. The front desk person also has a mask on, also has gloves on. And as I said, the most critical and dangerous thing I do every week is go to the grocery store. My wife makes me do that.
And Doc, I would invite you to try using a pulse ox. You can purchase one of these.
Yeah, I use them routinely. Yeah.
Perfect. Yeah, because a lot of these patients are apparently hypoxic silently, and that's one of the other indicators. Well, with that, I want to thank you again, Dr. Shaw. Welcome back. I think our audience continues to be impressed by the level of knowledge and recommendations, and I share a lot of your recommendations, and we sincerely appreciate you taking the time out of your schedule to be with us today. Dr. Shaw, do you have any other words you wanted to kind of add?
Thank you guys so much. Although the two of us and the rest of the world probably would want to stay with Dr. Gordon for all day asking these questions and having a good time.
Well, I gave him a couple of websites. Go to those and come to our getting back into practice. That's coming up not too long from now. So
I had to learn.
By the way, I congratulate you guys for putting this together. Virtual is here. It's hard, as you saw on this one. Somehow the computers went down. But it is the future. Not for everything. We still... I think of when Blockbuster came on. Some of you foreigners won't know what that is. Blockbuster came on. Oh, we're going to destroy movies. Did we destroy movies? No, no way. Movies are bigger than ever. We're still going to have virtual and face-to-face. Face-to-face is still the best thing. Thanks, you guys. You did a great job.
Thank you, gentlemen, for your time, and much appreciate your contributions to this project. We have the next session. Our wonderful colleague, Dr. Gina Dorfman, is currently staging, and with Dr. Sandeep Singh as the host, and we look forward to having you back in about 30 minutes. Thank you, Dr. Gordon. Have a wonderful day in the practice.
Thank
Thank
you.
you. Thank you, Dr. Carl. Have a great day.
You
Bye-bye.
too.